Welcome to our second episode of the GIFT webinar series called Women Up to No Good. My name is Dr. Fezile Khumalo, and I'm a research scientist here at the University of Cape Town, and I'd like to take this opportunity to welcome all of you. Like I said, I'm a researcher and I work in a very exciting field of trying to bridge the scientific research that we do as well as the practical application of it. And recently we have been working on a really exciting program called the GIFT test, and it's a genital inflammation test looking at vaginal inflammation, which is one of the risk factors associated with HIV acquisition. The GIFT test is currently being tested in 3 countries, and we're very excited to see where the next chapter of GIFT goes. And if you're interested in the work that we're doing, the link to the GIFT website and the work that we're doing is going to be posted on the chat, as well as the hashtags that we're going to be using for our social media discussions. Please follow GIFT Africa on your social media platforms and use the hashtags that Leila is going to post on the chat. So back to today's webinar. The series is called Women Up to No Good, and the no being the operative word here. And it is being led and run by the University of Cape Town with our partner institutions. And we are all for everything knowledge related to women's health, women's and reproductive health. And today's topic is on HPV with the hashtag HPV at Your Cervix. Cervical cancer, as some of you know, is caused by the human papillomavirus. It is a preventable disease that it unfortunately still causes thousands of deaths worldwide. Like other STIs, it can be prevented with consistent and regular use of condoms, but there is another alternative that is currently available to help in the prevention of the disease, and that is the HPV vaccine. However, like I said, women are still dying from this, and we are here to ask the questions about why that is, reflecting on what needs to happen, as well as connecting around this common topic of prevention being better than cure. So we've invited 3 very prominent speakers, both internationally and locally, who are very big players in the landscape of HPV, in the screening, in the prevention, and also in the application of programs that are currently available. They will each have a chance to talk on different standpoints about HPV as the disease and what needs to happen for us to be able to reduce the number of women being affected by this disease, and hopefully eventually eliminating it altogether. So I hope that we're going to have a very productive discussion with our experts, but we also welcome questions from our participants. So if there are any burning questions that you would like answered about any of the discussion points that our panelists are going to be discussing today, please put them on the chat, and we will get to them as soon as all the panelists have done their presentations. I would now like to introduce our panel of experts that will be talking to us today. If I can have all of you with your cameras open, please. First on the list is Dr. Ruanne Barnabas, who is the Chief of Division of Infectious Diseases at Mass General Hospital and a South African physician scientist. She's the principal investigator of the CAN-SHE study that assessed the impact of single-dose human papillomavirus vaccination in Kenya. Her work aims to identify effective and scalable HIV, HPV, and infectious disease treatment and prevention strategies to increase access across diverse communities and promote equity in health. She also serves as the advisor to the World Health Organization as well as UNAIDS. Next on the list is Professor Lynette Denny. Professor Denny is a gynecological oncologist and has been working in the field of cervical cancer prevention in collaboration with colleagues from Columbia University since 1995. She has done extensive research in cervical cancer prevention, including 3 cross-sectional studies comparing different screening tests, prophylactic HPV vaccine trials in HIV-positive women, and therapeutic vaccine trial in HPV-negative women. Her team is currently engaged in an NCI USA-funded trial evaluating screen and treat with HPV expert-safer HPV test. Last but not least, we have Dr. Zizipho Mbulawa. Dr. Zizipho Mbulawa is a joint medical scientist at the National Health Lab Services, Nelson Mandela Academic Hospital, and Walter Sisulu University in Mthatha. She's a member of the South African Medical Research Council Gynecological Cancer Research Center and has expertise in molecular epidemiology of the human papillomavirus. And her research has focused on the impact of HIV co-infection on HPV infection, transmission, and natural history on women, adolescents, and heterosexual couples. She has also focused on HPV and its associated diseases, health education, and health education in the general community. I would now like our first panelist, Dr. Ruanne Barnabas, to give us her presentation.
Thank you so much, Dr. Khumalo. It is a real honor to join you today, and I will be talking about HPV vaccination, where we are and where we are going. And I'm going to talk about the Kenshi study. And I love the name Kenshi because it asks the question, can she? And I'm happy to tell you the answer today is yes, she can eliminate cervical cancer. I want to start with the 3 messages that I hope to leave you with at the end of these 5 minutes. The first is, although we have effective tools, we have a long journey ahead to eliminate cervical cancer. Second, HPV vaccines are among our most effective vaccines with a high impact on individual and population health. And third, single-dose HPV vaccination works, and the evidence supporting single-dose vaccination continues to strengthen. In 2020, there were over 600,000 cases of cervical cancer and 340,000 deaths globally, with disparities in distribution. And you can see here on this map where the darker colors are, there are more cases, and the majority of cases for cervical cancer are focused in Southern Africa, in Latin America, and in Asia. And at the same time, countries with effective programs are expected to eliminate cervical cancer in the next few years. So, for example, Australia is on track to eliminate cervical cancer. So although elimination is possible, cervical cancer remains disproportionately a leading cause of cancer globally with high mortality. Everybody on this call shares a common purpose. People with cervical cancer, people with dysplasia, people with HPV infection, people in community partnerships, people in healthcare, people in academia, and people in industry. We share a common purpose to conduct rigorous science, translate evidence to impact health, address disparities, and eliminate cancer. And although we are on a virtual webinar today, I want you to feel all of us sitting together in a room. This is a picture from the last IPVC meeting, which is about HPV and cervical cancer. But I want you to picture all of us working together to eliminate cervical cancer. I'm going to move on to the second part of my message about vaccines. HPV vaccines are highly effective at preventing cervical cancer. And here I'm just showing an example from Sweden, where in the orange line are people who have not been vaccinated. And you can see that the cumulative incidence of cervical cancer is quite high with age. But if people are vaccinated before the age of 17, the number of cases of cervical cancer are very low. And you can see here that this line barely rises, it barely rises up this y-axis. The number is almost 0.1 cases per 100,000 persons. And I'm spending a few minutes on this graph because I'll show you a few others where you can see the impact of vaccination is really to have almost no cases of HPV. But in this graph, I'm showing you that with vaccination, you can have almost no cases of cervical cancer. And for people vaccinated under the age of 30, you can reduce the number of cancers by more than half. We have used mathematical modeling to predict what the impact would be to reach the global target of 90% of eligible girls vaccinated. And if we reach the global target, we would decrease cervical cancer by 89% and prevent more than 60 million cases of cervical cancer in the next century. And this graph just shows the number of cases of cervical cancer in this dark blue line without vaccination. And if we vaccinate everyone, we can reduce the number of cases significantly. But if we're able to add on screening in the blue and the red line, we can reduce the number of cervical cancer cases even further. So where are we? I mentioned that we want to reach 90% of girls who are eligible for vaccination with vaccination. So our target is here to reach 90% of girls. And where we are currently is about 20% of girls are vaccinated. Coverage remains low, and it's well below the target of 90%, due in part to the vaccine supply shortages and costs. This continues to be one of the most costly vaccines that we give to young people. We conducted a rigorous randomized trial and found that single-dose vaccination is highly efficacious with 98% vaccine efficacy for HPV 16 and 18. And this was an important study because currently vaccine regimens are either 2 or 3 doses. So I mentioned it was a costly study, and you can imagine multiplying that by 2 or 3. But we found that a single dose was very effective at preventing 16 and 18. And so here is 98% effective, preventing 16 and 18. And these cause 70% of cancers. And you can see here in the green dots are people who have not received the vaccine. And in the blue and red lines, you can see these are people who have received the vaccine with very few cases. And the same is true for the non-covalent vaccine, which prevents 90% of types that cause 90% of cervical cancer. And again, here you can see the difference between vaccinated, almost no cases, and compared to unvaccinated, where we see a steady increase in cases over time. So I mentioned that this is a costly vaccine. And when you think about a single dose strategy, that could save over $100 million in Kenya, which is the projected cost of rotavirus vaccination. When we think about whether this is cost effective, it's clearly cost effective. You can, certainly it's intuitive. Using 1 dose will cost less than using 2 or 3 doses. But we did do the math to show that if you use a single dose strategy, it would cost $2,700 per cases averted, compared to a 2-dose strategy where it would cost over $10,000 averted. So we could quantify the savings, and we could also think about what the savings would be and what we could use those savings for. So for example, in Kenya, where we did the Kenchi study, if we switched to single dose, it could cover the cost of rotavirus vaccine. So you can think about how cost savings can also be used to avert morbidity and mortality. We contributed to the evidence that demonstrated high efficacy of single-dose vaccination. I didn't have time today, but there were several other studies, important studies in different settings in Costa Rica, in India, in Tanzania, that all found the same results. We were able to demonstrate high efficacy of single-dose HPV vaccination, and this supported the WHO changing its policy to recommend single-dose HPV vaccination on April 11th, 2022. And several countries have followed suit, including here in this example, I'm just showing one of the first in the United Kingdom. but now 37 countries have adopted single-dose vaccination, including Tanzania and Nigeria, and the United Kingdom and Australia. So I'll just come back to the three messages that I want to leave you with. Although we have effective tools, we have a long journey ahead to eliminate cervical cancer. HPV vaccines are among our most effective vaccines with a high impact on individual and population level health. Single-dose HPV vaccination works, and the evidence supporting single-dose vaccination continues to strengthen. I want to thank the Kenshi study team, especially my co-principal investigator, Dr. Nelly Mogo, and everybody listed on the slide. And I'm thankful for your attention today, and I look forward to taking questions. And I'm just leaving you here with our main message. Thanks so much.
Thank you, Dr. Ruanne. And maybe you will tell us how we're going to be reaching that magic number in the question and answer session. Thank you for that enlightening feedback on the studies that have been conducted and how they have gone. Our next speaker is going to be Professor Lynette Denny.
Good afternoon, good evening, good morning to everyone, and thank you for the invitation to participate in today's webinar, and a warm welcome to all of the participants and co-panelists. I'm going to talk about one of the pillars for cervical cancer elimination as a public health problem. So I think you're all familiar with the WHO call from 2020 that by 2030, we need to have fully vaccinated 90% of girls aged by the age of 15 years. And we just heard from Ruanne that one dose is now considered adequate. The second pillar of the strategy is that 70% of women screened with a high performance screening test by age 35 years, and again at 45 years, and that 90%, this is pillar 3, of women with pre-invasive and invasive cervical cancer must receive appropriate treatment, including palliative care. The elimination target is that it should be no more than 4 cases per 100,000 women years. And when we think about the high incidence countries, they go up to 40 to 50 per 100,000. And those countries have a long way to go. What are the benefits of achieving these, the triple targets by 2030? And I think we've just seen some of the modeling presented by Ruanne. So the median decrease in cervical cancer incidence is expected to be 42% by 2045, and within the next century, 97%, which averts 74 million new cases. The median cumulative number of cervical cancer deaths averted will be 300,000 if we achieve these goals by 2030, more than 14 million by 2070, and 62 million by 2120, the next century. So how have we prevented cervical cancer traditionally? And where it has worked really well, particularly in the northern parts of the world, it has had a marked impact on the reduction of cervical cancer. But this approach requires psychological screening taken at regular intervals, organized programs with a system of call and recall. Women with abnormal smears are referred for colposcopic assessment, and at colposcopy, histology is performed to decide on whether the patient has indeed precancerous lesions. The patients are then recalled now for 3rd or 4th visit for treatment, which can be either an excision, such as LETs, or an ablation. But in the traditional method, the diagnosis must be confirmed histologically. There should be long-term follow-up provided post-treatment to detect recurrence and or persistence of disease. So the infrastructure for successful cytologically based, colposcopy-based cervical cancer screening, high-quality laboratories, functional referral systems, trained clinicians, access to healthcare facilities and treatment, and proper information systems that are linked to cancer registries, which are essential for monitoring and evaluation. These criteria are not really available in most low and middle income countries, resulting in very high incidence and mortality from this preventable disease. Just to go quickly through what in the current world currently has been investigated as alternatives to the pap smear, and started really, and we were one of the first groups to do this, was visual inspection of the cervix with acetic acid, with and without magnification. Currently, we are evaluating automated visual evaluation of the cervix using AI and machine learning, and there's ways to go with that method. And now recommended and most popular is molecular testing using nucleic acid amplification tests, also known as NAATs. These are either HPV DNA based tests for looking for high-risk oncogenic genotypes. These detect viral DNA. And there are also HPV mRNA molecular tests, which detect transcripts of viral E6 and E7 oncoproteins responsible for HPV-mediated oncogenic transformation of epithelial cells. Using HPV NAATs as the primary screening test prevents more cancers and saves more lives than either VIA or cytology as primary screening tests. And the WHO now in their guidelines encourage the use of HPV NAAT testing once a testing infrastructure is operational. Where VIA is the current primary screening method, there should be a rapid transition to HPV testing due to the inherent challenges with performance and quality assurance using VIA. That's a picture of a woman with cervical cancer, or a cervix which is invaded with cervical cancer. Next slide. So we have just published in September of the end of the year, point of care testing with expert HPV, looking to do a single visit, screen and treat for cervical cancer prevention. And I'll just give you some very, very brief details. We recruited and enrolled just over 3,000 women aged 30 to 65 years from the general population of Khayelitsha, which is a semi-urban township 20 kilometers outside Cape Town. All the activities occurred in our research site, which is located on the compound of a community health clinic. We use secondhand shipping containers and prefabricated buildings. 44% of the women we recruited were HIV positive. And we defined HIV positive more stringently than recommended by the test we used, which is manufactured by CEFAID, which tests for 14 high-risk types and gives you a result within 1 hour of running the sample, which is pretty rapid. And basically, we found that of the women we screened, 99% got their result on the same day. Same with the HIV positive and HIV negative women. In terms of detection of high-risk HPV in the whole population, 28% were HPV positive, 41% were HIV positive, and 17% were women negative for HIV. So you can see there's a huge difference between women who are infected with HIV and those not. The median waiting time for most patients was 1.5 hours. Of those women who we considered eligible for treatment and suitable for an ablative treatment, which we use thermal ablation, 95% received it, 91%, sorry, on the same day, and 95% within 2 weeks of being tested. We have very few complications. There were no serious adverse events. And just to give you some idea of follow-up, at 12 months post-thermal ablation, 40% of the women with HIV had cleared all HPV, compared to 65% of HIV negative women. And this is quite interesting because there are many different studies that have shown much higher clearance rates post-thermal ablation than we have. We tested women who were HPV negative, and we followed them up at 12 months, and 5% had acquired, 5% of women with HIV had acquired a new HPV infection in that year, compared to 6.4% of HIV negative women. There were no cases of CIN2 or cancer. So what are our concerns? Our data show relatively high rates of high-risk HPV persistence post-thermal ablation in both women living with and women not living with HIV. The literature is conflicted, some reporting high rates of HPV clearance, others, like us, lower rates post-thermal ablation. We definitely need to do more work on what are the predictors of failure of thermal ablation if we define it as persistence of HPV. And going forward, it may be necessary to develop adjunctive treatments to thermal ablation, such as, for instance, therapeutic vaccination or more effective destruction of the transformation zone. Sorry, that's the end of my slides. I've tried to keep to the 7 minutes, and I'm obviously happy to take any questions.
Thank you, Prof. Denny. We're not going to be taking questions now. We'll do everybody after Zizipho's presentation. But thank you for that wonderful presentation. Zizipho, please go ahead.
Good afternoon, everyone. So I'll be sharing with you some of the work we've been doing on cervical cancer and HPV awareness in rural Eastern Cape communities. The knowledge and awareness about HPV and its associated diseases is very insufficient in South Africa, especially in rural areas. HPV is not only associated with cervical cancer, but it is associated with a number of cancers, as I've just listed them here. We know that some countries are trying to incorporate HPV testing into screening and so on, and South Africa is also trying. However, without a proper knowledge on cervical cancer and HPV itself, the cervical cancer screening, testing, and vaccination will not really reach the target that is set up by WHO, as Prof. Denny has shared. So it becomes important that we somehow contribute in terms of improving the knowledge. So in my group, we've tried to conduct HPV and cervical cancer awareness activities in Eastern Cape, the Krizani and OR Tambo municipality. So I coordinate Walter Sisulu MP's HP3 community medicine and service module. So when the students, they start, like now they've just started, so we distribute or we attach them to 11 different clinics in OR Tambo. So since 2022, one of their objectives is to educate, which means is to conduct health education about topics, any topic. But between August and September, they focus on cervical cancer. So we design the posters, the education material in FOSA that they are going to use and share in their communities where they are attached. So what we did last year in one of the communities, we singled out one community to first investigate, to try and understand the status of their knowledge and awareness about cervical cancer, risk factors, prevention methods among women and men. Okay. So among participants in that community, only 26% of them were found to have overall good knowledge about cervical cancer. So the good knowledge will be out of all the questions that we've asked them, at least they need to score 65%, accurately score 65% of those questions. So only 26 of them, 26% had accurate knowledge. And among them, women with the majority who had overall good knowledge. one will say it was not really that necessary that men were part of the study because we're talking about cervical cancer. But remember, this cervical cancer, the risk factor HPV, it also involves males. And also in our communities, most of our communities, they rely on males in terms of financial support. So in order for women to be able to go for any of the cervical cancer screening or even treatment, they need financial support. They need any type of support from our fathers, from husbands, from brothers. So it becomes important that the male partners or the males in our community, they have accurate knowledge about cervical cancer. We've got HPV vaccination going on in South Africa. These children, they need to take their consent to parents. So if the parents in our communities, they don't have a good knowledge about HPV and vaccination and cervical cancer or all other diseases that can be prevented by this vaccination, they will not consent, especially that we know that there are a lot of issues around vaccination, all the vaccinations, which means now a good knowledge specifically on HPV vaccination, it becomes important to support that other element of high coverage in terms of vaccination. So the second part, we then conducted the education to everyone in all of those 11 communities that I've mentioned. These are just some of the pictures. So when the students, they get to the community, they first go to the clinic in that community. And then from the clinic, they get supported. Community members are still waiting for the service in their clinics. The students will start their education. They will distribute themselves in all of the units in the clinic and conduct the education. The nice thing is that also the staff, the clinic staff members, they find this very useful. They also support the students when they do all of these activities. As you can see, this was Gateway Clinic. You can see that the staff members are part of them. So this really is becomes a very nice platform because we know the waiting periods in our clinics. So the students, they have the whole day from 9 till 4, they are in those clinics. They even go outside. They organize to go to the high schools and conduct the education. This becomes also another platform that when they talk about an HPV, a sexual transmitted infection, the students, they tend to ask beyond HPV infection. They ask other STIs that we're not even there to talk about. So it becomes a very nice, and the fact that they see the youngsters talking about this condition, they becomes very freely to discuss. So when we leave those clinics, we leave all the pamphlets, the education material there so that they can continue to distribute. So this is in Xhosa and also in English, as you can see that poster. So 4 months after the education, we then go back to the communities to try and get the views about the health education that was conducted by the student. How do they view it? So these are some of the quotes from the clinic staff members where when we asked them what was the impact of the health education conducted by students when they were placed in their clinic. You can see here that they indicate that when the students are going around the waiting area, they tend to get more women to agree to take pap smear, and sometimes they come on their own. Once they finish whatever they visited the clinic for, they then go to the pap smear sessions consultation room to get their pap smear done. This second quotation, one nurse indicated that after that education, so more women, they came for pap smear, and around 2 women were found to have precancerous lesion. Those women, if they did not answer to the call when the students were talking about cervical cancer screening, I don't know what was going to happen with them, because now at least they were able to be referred to Nelson Mandela Academic Hospital for further management. And also the third quote tells us that the screening statistics was increased when the students were there, which means the students they have a positive impact to the community members. They somehow, their health-seeking behavior, it is improved when they hear the students talking about cervical cancer. And also the health service is also improved. We know that our clinics, they do have pap smear, they do offer pap smear, but if you can look at their statistics, monthly is very low. If I were to share in OR Tambo area, you will see the statistics that is very low, even though they see thousands per week, but they do not offer much of pap smear. But now when the students are talking about cervical cancer, their statistics is increased as well. So there is a potential that if the clinics as well, the staff members can somehow try and increase the rate they are educating about cervical cancer. The third part is when we visited specifically the high schools around the Chris Hani area. So in this, the way we designed this part of the study, we first get into a class. So in this case, we act as if we are part of the school staff members. So during their LO, the life orientation sessions, they give us those sessions. We first ask them questions, kind of they are writing a test on HPV and associated disease. We then mark those strips. You can see the poor knowledge, almost 99.2%, almost all of the high school learners, they had poor knowledge. And in this case, we even put up the cutoff into 50% because we were like, maybe they are still very young, but still most of them, they did not have good knowledge. But now after the education, you can see the knowledge becomes increased, they score higher. But remember, this is just a once-off education session, which means now if it can be a continuous education where the communities can get this education continuously, even if we also involve the media and so on, somehow it may stay, because maybe now if I can go back to those high school, their knowledge levels has grown, but now continuous improvement is what we need. This is very sad because the high school population, starting from age 10 up to, in our high schools, we even have age 32s. Those, they are already responsible at home. They need to sign those consent. So if they don't have knowledge, they will not be able to consent for vaccination. They will also not be able to take care of themselves. So afterwards, when we investigated the HPV prevalence among those high school girls, you can see the prevalence 76%. But the knowledge, what was the knowledge there? Less than 1%, they have a proper knowledge on cervical cancer and HPV. Even if you can break it according to the age group, still the HPV prevalence is still very high. So my take-home message is that even if we do have these 3 pillars from WHO, we are working towards them, but for all of them, they need a proper education. In order for screening to happen, no women will go for cervical cancer screening if they don't have a good knowledge about it. No one will agree to do such kind of testing in our rural areas. No one will consent for their children to be vaccinated because the knowledge is not there. So we need to improve in terms of knowledge so that we can support all of these pillars. And in terms of the knowledge, we need to make sure that the knowledge that is shared in our communities is accurate, even if we try our best to make it simple, but it still needs to be accurate to motivate them to support all of these pillars so that we can be able to meet them. So this is really in work that involves different collaborators, Walter Sisulu, MRC and NHLS, and this was also funded by NRF and MRC. And the students of Walter Sisulu, I also thank them. They become very excited after this, when they come back, when we conduct a weekly evaluation of the activities in communities, they become very excited when they share the way they engage with the community members, the way they ask. Thank you very much.
Thank you, Dr. Zizipho, for such encouraging work that is happening within our communities. I would like to invite all our panelists to have their videos on as we get into the question and answer session. While we are just waiting for the questions, I think one of the biggest lesson that I have learned from all three talks is just about equitable access to health. So in different forms, whether it is having a vaccine that is affordable, so that everybody can get vaccinated, whether it is the use of language or education that is accessible to my mother, my grandmother, all the support systems that will allow for that access to be achievable, but also the health system itself. If it is not equipped to be able to support the population, then what is there to do? Ruanne, the first question for you is, can you please confirm if the vaccine was Gardasil 9?
So in the Kenchi study, it was a 3-arm study, and we compared Gardasil 9 and the bivalent Cervix vaccine as well. And both vaccines had very high efficacy against 16 and 18. And then the non-valent vaccine had high efficacy against the additional 5 high-risk types as well. So we were able to use both vaccines in the trial.
And the single dose, was it before first sexual contact, as in childhood, or it needs to be a single dose before age 17? What is the recommended age of vaccination, and what is or for the greatest benefit?
Great question. The WHO has recommended single dose vaccination for girls and boys aged 9 to 20. When supply of vaccine was constrained, we did think only about vaccinating prior to sexual debut, but the Kenchi study enrolled participants who were sexually active and who reported 1 to 5 lifetime partners. And we know from those results that the vaccine will still have an impact. And the results led directly to the guidance for 9 to 20-year-olds. If I may, Dr. Khumalo, I did see the question also about vaccinating boys, and since the WHO guidelines recommend vaccinating boys as well, I want to share that there is a good evidence to support that gender-neutral vaccination accelerates the rate at which we can eliminate cervical cancer, because we're able to break the transmission as well and prevent HPV infection and onward cervical cancer. So as we are now living in a era where we expect the constraint of vaccine supply to be lifted, we should be having these conversations about vaccinating as many people as we can using gender-neutral vaccination and catch-up.
Just to follow up on that, while we're still talking about the vaccine, where is South Africa's shift? Basically, where are they towards going the single dose route, or are we still using the same strategy?
Great question. So probably somebody on this webinar knows more than I do. It is currently being discussed, and I hope that we will have news soon, but it's currently being discussed.
It has actually been approved.
Great.
Yeah, it's been approved, as has the transition to HPV testing. I heard this actually, it's very hot off the press. But it's been in the last few weeks, it's been through the appropriate committee. So we will be transitioning to 1 dose.
Oh, congratulations. That's fantastic news, and what a wonderful opportunity for me to learn it and for all of us. Thank you so much, Professor Denny. That's great.
And just on that, is there how South Africa or the government or the health sector in South Africa is keeping track of vaccinating? Is it just on the public health front that these stats are coming from, or is it both public and private when we talk about vaccine coverage?
It's such a good question. I had a quick look and I wasn't able to find the reports in the private sector, but somebody on the call might know more than I do.
There's not good information, because in the private sector, people pay out of their own pockets, and the medical aids are not yet funding vaccination. So there is now, they've moved the eligible girls to grade 5, and it was grade 4. in addition, independent private schools will be included in the outreach.
This one is for you, Prof. Denny. I know you have done a lot of work on barriers to women getting tested for CACX. In your study, did you evaluate reasons for participating versus not in the test and treat? This was a huge study that enrolled rapidly, so they were hoping that buy-in from the community was high.
I would say it is. You know, one of the things that I've been critical of ourselves about is that we've never really measured the impact of our project on the community around us and whether it has changed health-seeking behavior. We've never measured it in either a qualitative or a quantitative way. But we've been there since 1995, and we're known as those women in the containers at the back. And we never struggle to recruit. Women use us actually as the health service because the quality of care they get from us is much greater than the overcrowded, understaffed primary healthcare facilities. And there's tremendous, and every woman fills out an anonymous questionnaire when they leave us at the end of their screen and treat day. And all we get is positive feedback. And over the years, I mean, it's what's nearly 27 years, we've done a lot of education with women. Even Zizipho has done some work with us. And we've done a lot of education about encouraging women to view their genital tract as a critically important part of their body, which is beautiful and to be respected. And it's not dirty and it's not down there, and no one owns it but you.
Thanks for that. I actually, on that note, the replication of programs like yours in other communities, how has the uptake been? Because sometimes when you have something that works is it funding, is it resources that are not available and that's why it's very difficult to replicate, or do they need to be tailored for specific environments, and that's why it becomes very difficult to try and replicate them in different areas?
Yeah, I mean, I think a lot of factors have to be, there's lots of moving parts in doing cervical cancer prevention, ranging from vaccination to education, as Zizi has pointed out, and finding an algorithm or a protocol that is woman-friendly, that does not require her to miss days of work, that is respectful of her womanness, and where patients are given really good, accurate information. So, for example, we don't accept a signature for consent in my studies. Women have to pass a test before they can sign consent, what we call a comprehension checklist. And they have to get 10 out of 10 or 20 out of 20 before they can even consider signing. So we put a lot of emphasis on giving patients information they can understand and they can share with their friends and their cousins and their children. It's a constantly evolving, spiraling learning process.
Thanks for that. I actually wanted to follow that up with Dr. Zizipho on just the use of language in your programs is so critical to be able to reach the audiences that you interact with. So what Lynette, Prof. Lynette just said about just having the women having the comprehension to be able to say, yes, I can participate in this. But then in a community that is quite diverse, trying to get that one voice that will reach a bigger audience, I'm sure that is something that you have had to deal with a bit in your work.
Yeah, that is why the education needs to be a continuous one, not just a once-off kind of a thing, so that we make sure that they build. You need to have a first knowledge before you can add up. So you keep on adding. You don't expect them to understand and accept everything on one day. So you keep on building.
Okay. So one of the questions, I think I'm going to take one last question before I say my thank yous, and that is just on the barriers, especially in LMICs on cervical screening, implementation, uptake, etc. So what, if I can get one barrier from each of you as a sign off, and maybe it could be a call to action for our audience members to say, hey, I'm working in that space. So if that's a barrier, then, you know, I can partner with any of these scientists on their next study or in studies that are currently happening.
I'd like to quote one of my favorite gynecologists, whose name was Mahmoud Fatala, and he was an Egyptian who was a real fighter for women's rights. And he said, and I won't get it perfect, but what he basically said was that women are dying not because we don't know how to keep them alive or how to make them better. They're dying because we haven't yet, as a world, as a society, decided their lives are worth saving. That's the barrier.
Thank you. Zizipho?
Thank you. Well, I will not say it's a barrier, but somehow it is, because after that screening, they need to come back for their results, right? So we tend to lose them a lot. So it becomes very frustrating as well that you have them with a high grade, but you are not able to locate them. So I don't know what type of system that we can be able to have in place to be able to help us in locating and educating them further to follow up their results.
I think a real barrier for us is that we need to think differently. You know, we've thought about HPV vaccination in a specific way before sexual debut, 2 or 3 doses, but the evidence has been mounting now for many years, and we have strong evidence to support gender-neutral catch-up vaccination for 9 to 20-year-olds at least, girls and boys. And someone made a comment about everyone, and you know, we need data on additional strategies as well. So my call to action is think differently, and let's really focus on gender-neutral catch-up vaccination for all.
I would now like to just take this opportunity to first thank the panelists. You have been absolutely brilliant, and the work that you have taken on, continue to take on, is going to change, you know, our ability as women to be present, to continue working in this place. So, and if there are people in the audience who resonated with any of the work that our panelists spoke about, they're more than very happy to be in touch and to, you know, have further discussions about this. I would also like to thank the Jive Media team, who have been working tirelessly in the background, making sure that this webinar goes off without a hitch, as well as the GIFT team at UCT, who come up with these discussions and topics of discussion, and the people that we invite onto here, so that we have more people knowing about topics that are important to us as a research group, but also to us as women, and changing how women's health or reproductive health is communicated to a wider audience than just us scientists. So on that note, can I also please remind that if you have HP, if you need to get CPD points, please email me on fezile.khumalo@UCT, so that we can add your registration details onto the HPCSA website for your CPD points. Thank you so much, everyone, for another wonderful discussion, and we look forward to seeing you again in more of our webinars. Thank you.